Thank you, Melanie. This was a very nice presentation. I'm really pleased to be here. Thank you, Christina and Melanie, for inviting me. I just want to tell you that I have a little bit of cold, so if I stop a little bit and I drink water, please forgive me, because I want to be able to talk to you throughout this presentation. Okay, so what are the evidence? We often have our patient, I don't know where to advance this. Do I go like this? No? Do I go like this? Yes. Okay, so what are the evidence? We often have our patient, before they come to us, going on the internet and trying to find out what are Kegel exercise, what are pelvic floor muscle training, and they come up with very different information. Sometimes they think that doing buttocks exercise, even doing push-ups, will help them with their pelvic floor. And there are all those units that are supposedly making you having a really strong pelvic floor. So we see that, but on the other hand, we have evidence. So today, what I will try to do with you, I will try to answer the following question. This will be the content of my presentation, and this will be done with the chapter on conservative management from the ICI. So we will ask the question, is pelvic floor muscle training effective in prevention and treatment of incontinence? What is the most effective pelvic floor muscle training program? Or cones, e-stim, magnetic stimulation effective in the treatment of urinary incontinence? And is pelvic floor muscle training effective for preventing and treating prolapse? So as Melanie said, I will use the International Consultation on Incontinence book. It was last published in 2017. We are already working on the new book to be presented next year at ICS in Las Vegas. So there are maybe a few added paper, but the main recommendation are staying until maybe this conference, and I will point you where it might change. So the ICI book was created in partnership with the International Consultation of Urological Disease. It is updated every 4 years. It has 2 volumes. It includes a lot of contributors, and it's a key text to refer for clinical practice and for research if you're doing research. However, if you don't have time to read those 2 big books, there is the recommendation of the ICI book, and it's made by chapters. So there are recommendations for conservative management in that paper. So the method we used to give level of evidence and grades of recommendation was to first do a literature search, and we were helped with Sheila Wallace from the Cochrane Incontinence Group to look at all the published abstracts and paper in the area of incontinence and conservative management. We did assess the trial using the CONSORT checklist for all the randomized trial, and we also looked at the risk of bias according to Cochrane collaboration. Just a brief reminder of the level of evidence. As you know, the level of evidence will go from level 1, which is the highest level of evidence, which involves usually a meta-analysis of trials that goes all in the same direction, supporting an intervention, or a good quality randomized trial, but a very big, good trial. Level 2 is lower quality randomized trial where, for example, you would have less than 80% of the patient at the follow-up, or meta-analysis with heterogeneity, which means that not all the results go in the same direction. Level 3 would include good quality retrospective case control studies or good quality case series, and level 4 would include expert opinion. This is in the case where there's no evidence, but based on first principle, based on physiological and anatomical baseline, we can suggest intervention. Grade of recommendation. The most important grade is grade A. It consists of only level 1 evidence, and the recommendation is effectively mandatory and placed within the clinical care pathway. So when you have a grade A recommendation, it can change actually clinical practice. So this is an important one. Grade B consists of level 2 and level 3 studies, and the majority of evidence from randomized trials supporting an intervention. Grade C, level 4 or majority of evidence from level 2 and 3 studies. And grade D, which is also an important one, that's when there's no recommendation possible. So let's answer our questions now. Are pelvic floor muscle training effective in the prevention or the treatment of incontinence? And now I'll be talking about women in general, not women in pre- and postnatal time, because I didn't have time, but please go to the book if you want this information. We were quite happy to see that in the last chapter, we found one trial about prevention of incontinence. This was the first time that it was not a prevention trial in pre- and postnatal women, but in older women. It was a randomized trial in elderly women, a large one, and the level of evidence for this addition is level 2, grade C. You will understand why the grade C. The intervention was kind of a workshop. It was a multi-component behavioral modification program with pelvic floor muscle training teaching, bladder training, and other behavioral skills. It was delivered in a 2-hour workshop and then followed up by 2 to 4 weeks later by individual session with a therapist. The control intervention was no intervention, and the results after 12 months, remember it's a prevention study, the continence status was the same or better. So the prevalence of incontinence was the same or better in 56% of the prevention group, compared to 41% in the control. So the control, there were more people being incontinent. So the reason why it's a grade C is that relatively high rate of non-completion in that trial. However, I think this is an interesting way to go for prevention in older women, and we should build on this first trial. Now, what about treatment of incontinence with conservative management with pelvic floor muscle training? Well, here we have a grade A, like I said before. Evidence level 1, and this was on changes in the last ICI book. In the intervention versus control, we had 31 trials comparing PFMT to no treatment or sham, and the results are that PFMT cures or improves symptoms of stress and all other type of incontinence. It may reduce the number of leakage episodes and the quantity of leakage while improving reported symptoms and quality of life. This is based on the new review, Cochrane review, that was done after the ICI in 2018. What is most important here is that the benefits are shown across age cohort, young and old, in various cultural settings. It was covering 17 countries. Various UI type. There is now new information for urge incontinence, new results for urge incontinence and mixed incontinence. It was using several different training regimens, which included now mobile technology, and it was included a lot of outcome measure and now cost effectiveness, and it was positive in that way. So I think this is probably PFMT for incontinence. This is where we have the highest level of evidence. What is the most effective pelvic floor muscle training program now? We asked that question in the chapter. We had 20 new trials asking that question, and we had 12 comparison. First thing, held professional taught and supervised pelvic floor muscle training versus without the supervised pelvic floor muscle training. Well, when it's supervised, it's more effective than self-directed. This is evidence 1, grade A. Individual versus group. Now, the data was unclear, but please, on Friday, attend the session on physical therapy because there's a new trial that will maybe resolve this question. Indirect versus direct training method. Based on limited evidence, there were 8 trials. Indirect method of pelvic floor muscle training are not better than direct pelvic floor muscle training. So Paula method, transverse abdominis method, hip abduction method do not appear to be better than regular pelvic floor muscle training. Adding other modality to PFMT, there's no clear benefit of adding those other modalities. So abdominal exercise, Pilates, hip muscle exercise do not seem to add to regular pelvic floor muscle training. Adding resisted device, there doesn't seem to be either added benefit. Pelvic floor plus clinical or home-based biofeedback, here again the benefit is unclear. And again, on Friday, a big randomized trial may answer this question. I think that, however, even if we see that there's no clear benefit of adding anything to PFMT, we need to be clinicians, and we need to see if our patient need that biofeedback to better understand how to contract their muscle. So there is some specificity that remains, and this is not picked up by those trials. Now, are cones E-stim and M-stim effective in the treatment of urinary incontinence? Vaginal cones, there's evidence level 2, grade B, and this was unchanged. There was not so many new trials on vaginal cones. Vaginal cones versus no treatment, vaginal cones is more effective than no treatment, but when used with supervision by a trained healthcare professional. And in those trials, it was not just the cone given to the patient, but the cone with the health professional explaining and supervising the patient. So that's when it's better than absence of treatment. Cone with the healthcare professional versus PFMT, they seem to have similar effect. Vaginal cone with the health professional plus PFMT versus PFMT, there was no added benefit from the cone. Again, vaginal cone may be inappropriate in some cases due to the inability to hold the cone or due to discomfort. And again, I think that clinical knowledge should help you decide if the cone is a good intervention for your patient. Electrical stimulation, again, not so many trials, new trials in electrical stimulation. Evidence level 2, grade B. For all type of incontinence, E-stim may be more effective than no treatment. However, it is efficient for improvement of incontinence, not for cure. It doesn't appear to be as effective as PFMT, for example. So for stress and mixed incontinence, E-stim plus PFMT may be of no added benefit than PFMT. And for OAB and urge incontinence, maybe that's where E-stim appears to be more effective. Compared to medication, it appears to be more effective, as effective as medication, but without the side effects. So this is interesting for OAB. Again, some women will experience some discomfort with this treatment, especially those with drier vaginal mucosa. So again, I think clinical expertise is required to know which patient will best benefit from E-stim. Magnetic stimulation, really not many trials in the new chapter. There's 11 trials in all. We have grade D and grade C for magnetic stimulation because unfortunately those trials are really small, not well done, and there's no strong recommendation possible based on the current conflicting evidence for magnetic stimulation. Now, let's talk about prolapse. Am I doing it with time? 5 minutes? Okay, I'm okay. Is PFMT effective to prevent or treat prolapse? So let's look first at the evidence for prevention. That was nice because we had 2 new trials on prevention. This was evidence level 1 and grade of recommendation B. So what we found was that there was 1 trial immediately after delivery in postnatal women, 13% of them who had stage 2 prolapse. And it appeared that early on, immediately after treatment, PFMT did not appear to influence the development of POP at 6 months if the treatment was initiated just after birth. So maybe it was a little bit too early. Maybe 6 months is not where the prolapse is developing. Look at the other study. It was done this time in middle-aged women. 55% of them had stage 2 or greater prolapse. So this is secondary and tertiary prevention. A pelvic floor muscle training intervention was delivered 12 years after childbirth, and it resulted in fewer prolapse symptoms 2 years after this intervention and less uptake of treatment for prolapse in the group that was treated by PFMT. So PFMT can prevent symptoms of prolapse which develop in longer term. And this is quite interesting. Maybe those women, middle-aged women, premenopausal or at the age of menopause, we should maybe look at them in more depth, because this is also the time where incontinence may start. So prevention trials in this time should be encouraged. So I think this is good. Now, for the treatment of prolapse, there were 7 new trials out of 13, and I know that since the last ICI, we have a lot of new trials on prolapse. So PFMT versus no treatment or other control, PFMT is effective in reducing pelvic floor symptoms in women with prolapse. This is level of evidence grade A. It is effective in alleviating specific prolapse symptoms, so the sensation of the bulge. This is level 1, but grade of recommendation C, because it's not all the trial that support this. There is no evidence, however, that PFMT is effective in reducing the signs of the POPQ stage, so grade of recommendation B, level 1. So it appears to be affecting more the symptoms than the signs of prolapse. And lastly, perioperative pelvic floor muscle training does not appear to improve the symptoms in women undergoing the surgery of vault prolapse. And this is 1 trial and grade B. So in conclusion, overall, there's increasing evidence to support conservative management as the first line of first-line treatment for incontinence and prolapse, and you can see that we had a lot of new trials. We still need large, well-designed trial with longer-term follow-up using high-quality outcome and looking at cost-effectiveness of those interventions, both in treatment and in prevention. So recommendation, if you want to do research tomorrow, use standardized ICS terminology, report details about the intervention. Often we cannot replicate the studies because there's not enough detail. Please, if you do research, compare the new methods with the best available evidence and use power calculation to have a well-built trial, and avoid large sample size with really weak intervention. You better have a smaller size trial with a best available intervention. So I would like to acknowledge my colleague who participated to the ICI book. Mélanie Morin was one of them, and the Cochrane group, and I thank you for your attention.